There is a moment in modern medicine that feels almost unreal. A surgeon removes a healthy kidney from one human body, carefully preserves it, and then places it inside another human body. And if everything works, the new body starts living again with that kidney doing its job silently, every second, filtering blood like nothing ever changed. That is kidney transplant surgery. And despite how normal it sounds in hospitals today, it is still one of the most complex systems in global healthcare. Because this is not just surgery. It is logistics. It is economics. It is timing. And above all, it is scarcity. Every year, hundreds of thousands of people globally suffer from chronic kidney disease. Many eventually reach a stage called kidney failure, where the body can no longer filter waste properly. At that point, two paths usually appear. One is dialysis treatment. The other is kidney transplant. Dialysis keeps a patient alive by artificially filtering blood multiple times a week. It works. But it is not a replacement for a healthy kidney. It is more like a temporary external machine keeping the system running. A transplant, however, replaces the function entirely. And that difference changes everything. But here is where the story becomes uncomfortable. There are far more patients needing kidneys than available donor organs. Always. This imbalance is not small. It is global. In many countries, waiting lists stretch for years. Some patients never receive a transplant in time, which turns kidney transplantation into something very unusual in modern healthcare. A system where demand consistently exceeds supply. And in economics, that creates pressure. Not in money alone, but in ethics, logistics, and policy. Because every kidney donation represents a rare event. A life lost in one place. A life saved in another. Two realities connected by one decision. That emotional weight is why organ donation systems are heavily regulated worldwide. Governments, hospitals, and medical organizations work to ensure fair allocation through matching systems based on compatibility, urgency, and medical need. Blood type, tissue compatibility, medical history, waiting time, geographic availability. All of it becomes part of a silent ranking system determining who gets a second chance first. And that is where modern healthcare meets uncomfortable math. Because even with perfect systems, scarcity remains. And scarcity always forces prioritization. Meanwhile, the cost structure of kidney transplant procedure adds another layer of complexity. Surgery itself is expensive. Post-operative care is long-term. Patients need lifelong medication called immunosuppressants to prevent rejection of the new organ. These drugs suppress the immune system so the body does not attack the transplanted kidney, which is necessary, but also risky. Because a suppressed immune system makes patients more vulnerable to infections. So even after a successful transplant, the journey is not over. It continues. For life. That is something many people do not realize. A kidney transplant is not a finish line. It is a new system of living. And globally, healthcare systems carry enormous financial pressure managing end-stage kidney disease. Dialysis alone consumes massive portions of healthcare budgets in many countries. This creates a strange paradox. Keeping patients alive through dialysis is continuous expense. A successful transplant can reduce long-term cost. But the upfront cost of surgery and donor matching is high. So systems constantly balance short-term affordability versus long-term efficiency. That is healthcare economics in its rawest form. Numbers versus lives. Budgets versus biology. And in the middle of it, patients waiting for calls that may or may not.
The real complexity of kidney transplant matching system begins after a donor becomes available. Because not every kidney can go to every patient. Compatibility matters a lot. Doctors test blood type matching first, then tissue compatibility, then cross-matching to ensure the recipient's immune system is less likely to reject the organ. Even with advanced testing, rejection risk never becomes zero. That uncertainty defines transplant medicine. Not perfection, but probability management. And probability, when it involves human life, becomes emotionally intense. Meanwhile, transplant centers operate like highly coordinated networks. A single successful transplant may involve surgeons, nephrologists, laboratory technicians, coordinators, transport teams, and legal authorization systems working together in tight time windows. Because kidneys from deceased donors have limited viability outside the body, time is not flexible here. It is biological, which means logistics can directly influence survival outcomes. That is something most people never think about when they hear organ transplant. They imagine surgery. But behind it sits an entire infrastructure designed to move biological material across cities or sometimes countries within hours. And this is where modern technology quietly transforms healthcare. Digital matching systems, national organ registries, real-time hospital coordination networks, advanced surgical tools, all working together to reduce delays and improve outcomes. But even with all this progress, one major problem remains unchanged: supply shortage. In many regions, donor registration rates are still not high enough to meet demand. Cultural beliefs, lack of awareness, and misinformation often influence public participation in organ donation programs. And this creates a direct human consequence: more waiting, more uncertainty, more preventable loss of life. At the same time, living donor transplants have become an important part of global kidney transplant systems. In many cases, a healthy individual donates one kidney while continuing to live a normal life with the remaining one. Because the human body is uniquely adaptable in this way. But even living donation raises ethical and economic questions. Should donors be compensated? How do you prevent illegal organ trade? How do you ensure fairness and prevent exploitation? These are not medical questions alone. They are policy questions. And different countries answer them differently, creating a fragmented global system. Meanwhile, medical outcomes for kidney transplant patients have improved significantly over decades thanks to better surgical techniques and improved immunosuppressive medications. Survival rates today are far higher than in early transplant history. But the journey remains complex. Long-term medication adherence is critical. Regular monitoring is necessary. Lifestyle adjustments are often required. Because the immune system never fully forgets what it sees as foreign. It only learns to tolerate it under suppression. That means transplant patients live in a carefully managed biological balance for the rest of their lives. And any disruption in that balance can create serious complications. Despite all these challenges, kidney transplantation remains one of the most impactful achievements in modern medicine. It transforms end-stage disease into continued life. But it also exposes something deeper about modern society. Even in an era of advanced technology, life-saving medical solutions are still constrained by availability, economics, and distribution systems. Science can solve the biological problem, but society must solve the access problem. And that gap between ability and availability is where the real global challenge sits. Because every year, new patients enter waiting lists. New technologies improve outcomes. But the fundamental question remains: